In this presentation, I want to take a closer look at thiamine deficiency. Now, rather than classify thiamine deficiency as a type of beriberi, let's first look at it from the cause of the thiamine deficiency. Depletion can be seen in as little as 2 weeks, and clinical symptoms can develop in 3 months. So first, we're going to consider thiamine deficiency as a result of poor absorption. If we first consider dietary inhibitors, these would be thiaminases. These are found in raw fish, and these will act to cleave thiamine in the GI tract. So someone who has a diet high in sushi, this can be a concern. Second, anti-thiamine factors. These are found in foods such as tannic and caffeic acid. These anti-thiamine factors can oxidize thiamine in the GI tract. And the third inhibitor would be alcohol. So we see chronic alcoholism listed here because alcohol itself will inhibit thiamine transport 1 and 2 expression in the GI tract. And thiamine transports 1 and 2 are necessary for thiamine absorption. So knowledge of these inhibitors are important as you review a client's diet history. Clinically, we also need to consider malnutrition, malabsorption syndrome, as well as gastric bypass. Malnutrition and malabsorptive syndrome sort of can cause each other, if you will. Malnutrition can eventually result in a malabsorptive syndrome because the GI tract is normally replenished at a regular rate. That becomes compromised during malnutrition, so you can result in a malabsorptive syndrome. And then malabsorptive syndrome is really kind of an umbrella term that refers to malabsorption of either a single macronutrient or multiple nutrients. So for example, if you're not absorbing carbohydrate foods well, and the enriched carbohydrate products have been providing a significant portion of your thiamine in your diet, this can lead to a deficiency and ultimately malnutrition. Gastric bypass actually shortens the GI tract and may remove critical surface area where nutrients are absorbed. Careful dietary management and use of supplements are critical in this population. We move on to poor intake. First, notice that chronic alcoholism and gastric bypass are also linked to poor intake. Alcoholics frequently consume a poor diet, and gastric bypass patients are not consuming the same quantities of food as prior to surgery. Diets that are high in polished rice have thiamine as well as other nutrients processed out, so other sources may need to be added to those individuals' diets. And PN stands for parenteral nutrition, also known as intravenous nutrition, and these solutions can be created without thiamine. To create a solution without thiamine, you're intending that typically that individual is only going to be consuming or beyond that TPN solution for a very short period of time. If a patient needs to be on a sustained parenteral nutrition therapy, you would want to ensure that thiamine is part of that solution. Next, we're going to look at increased utilization. These are periods when the body has an increased needs. They might be for a set period of time, or it might be sustained. Pregnancy and lactation are common periods and of this increased need for thiamine as well as other nutrients, and maternal vitamins play a critical role in preventing thiamine deficiency. One concern is if a lactating mom does not understand the need to continue to use maternal vitamins while they're nursing. Fever, sepsis, and malignancy will significantly increase needs quickly and can be for a sustained period. And remember that depletion can be seen in 2 weeks. There is concern with malignancy since the tumor also requires thiamine, and the question comes up of how much do you supplement. Hyperthyroidism results in an elevated metabolic rate and without medical management will be sustained. Thiamine supplements may be necessary and should be managed with medication. Refeeding syndrome occurs if an individual has been depleted or has not consumed enough regular nutrients for a sustained period of time. While a major concern for refeeding syndrome is the shifts that can occur among fluids and electrolytes, thiamine is suddenly needed in higher amounts as the body upregulates normal carbohydrate metabolism. Our fourth area is we can see excess loss. we see two ways that it can be lost through the urine: renal replacement therapy and diuretic use. Remember that thiamine is a water-soluble vitamin, and these can be instances where more thiamine is lost in the urine than is normally allowed. And then diarrhea and hyperemesis are two ways that we see thiamine lost through the GI tract. So the diarrhea will cause excess thiamine to be lost through the bowels before it has had an opportunity to be absorbed, and hyperemesis, or excess vomiting, can cause the thiamine to be lost from the stomach before it's had an opportunity to flow through the GI tract to be absorbed. Now, in this next slide, we're going to consider the organ systems and the related symptoms. So the organ system, it can be cardiorespiratory, and we see lower extremity edema in adults or generalized edema in infants, pulmonary hypertension, right-sided heart failure, tachycardia, or tachypnea. Now, in general, with cardiorespiratory, we also will see an enlarged heart. For gastrointestinal, we link anorexia, constipation, diarrhea, and vomiting symptoms. For musculoskeletal, it's linked to muscle atrophy, peripheral neuropathy, and weakness. And finally, for the nervous system, we see ataxia, encephalitic presentation, impaired cognitive development, nystagmus, and ophthalmoplegia. Now, this is where, when we look at these organ systems, this is where the names or the classes of beriberi have been developed. So wet beriberi is linked to cardiorespiratory, gastrointestinal beriberi with the gastrointestinal tract, and dry beriberi is linked to musculoskeletal presentation, whereas Wernicke-Korsakoff or cerebral beriberi is linked to the nervous system. Now, what's important to remember is that while a case of beriberi may be classified as wet beriberi, for example, because the prominent symptoms are related to the cardiovascular system, the patient may also exhibit ataxia or muscle weakness. So they may exhibit symptoms from other classes or types of beriberi. Now, let's review just very briefly the functions of thiamine. So the blue circles will highlight the primary locations where thiamine acts as a cofactor. And what we see, so first, number one, pyruvate moving to acetyl-CoA in glycolysis. And then the second location where thiamine plays a role as a coenzyme is moving out alpha-ketoglutarate to succinyl-CoA. And then finally, number three, we see the pentose phosphate pathway moving on to pentoses and nucleic acids. Now, the red circles will indicate the two byproducts that will build up if there is not enough thiamine. So if pyruvate cannot move to acetyl-CoA, you see a buildup of lactate. If alpha-ketoglutarate cannot be processed to succinyl-CoA, then there is a buildup of glutamate. In general, we see thiamine deficiency cause mitochondrial dysfunction, which, as we follow all the three arrows downward at the bottom of the slide, we see neuroexcitotoxicity, and this causes damage to neurons. We see increased reactive oxygen species and increased lipid peroxidation. These last two will contribute directly to cell death. But now in this slide, I want to pull out how the thiamine deficiency specifically affects diabetics with the increase in diabetes in the population. This is a genuine concern. So we see this normal hyperglycemia. With a thiamine deficiency, hyperglycemia is augmented. We see an increase of hyperglycemia, so higher levels of glucose than even prior with that diabetic. If the glucose cannot move through glycolysis and the Krebs cycle at a normal rate, this contributes to that hyperglycemia, and pyruvate and lactate and glutamate are considered highly reactive glycolytic metabolites. They will tend to react with proteins and amino acids. As a result, we see the body seek other ways to handle the excess glucose. So one of the things that it does is the polyol pathway. This is where glucose is converted to sorbitol and then finally to fructose. This elevated levels of sorbitol and fructose are linked to microvascular changes in the retina, kidney, and nerves, so contribute to retinopathy, nephropathy, and neuropathy that are associated with diabetes. The hexosamine pathway is stimulated, which can affect nerve conduction. AGE are the advanced glycation end products formation. That's proteins that are bound to glucose products. These can alter the function of the cell and result in increased reactive oxygen species development. And finally, it also activates DAG, or diacylglycerol, and this develops or contributes to an increase in protein kinase C. These activate the thickening of the basement membrane, the vascular occlusion, increase permeability, and ultimately increase angiogenesis. So I think this is an interesting aspect of managing a thiamine deficiency for your diabetic patient. And in this final slide, I wanted to talk just briefly about thiamine assessment. Now, liquid chromatography of the whole blood is considered to be the most sensitive. That's not always able to be requested. I think it can be a little more expensive than some of the other methods, but it is sort of, I don't know if I want to say gold standard, but it is considered to be the most sensitive. But you see on the left, there are other ways to evaluate or assess thiamine levels. Some of these are better done if you had a base level and you look at it over time, but that's not always possible if you suspect thiamine deficiency.